And we're recording. So I would also like to get out of this. Oh wait, I can see the chat box here. I can't always see the chat box when I'm on my screen. I don't know why. It's weird like that. See if I can move it out of my way so I can actually see it. If I don't see your question, please just say something so that I know that you're out there looking for information. So we'll just talk in general about musculoskeletal. I know what they look like. So we talk about pediatric musculoskeletal development. So of course this starts in utero, right? We have all kinds of in utero information there. Um, Babies are born as normal tone. The normal baby should have normal muscle tone. You know, they have those developmental things, but their muscles are fine. What's not normal is hypotonia, that floppy baby that doesn't do much, or hypertonia, the one that's really, really tight. Those are considered abnormal. Now, a lot of things are not seen at birth, but some of them are. Just remember that whatever is not normal, whatever is not normal is abnormal. Their bones and their fontanelles. Remember that babies' fontanelles are born open. The fontanelles on the top of their head are born open, and they close over the first couple months. Okay. The long bones, which are like the leg bones, like your calf, your bones in your legs and your bones in your arms, right by your joints, below your knees, above your ankles, are growth plates. Now these growth plates are open, and they stay open until you hit puberty, and start going through that. You start hitting puberty, and then they become solid. So kids' bones are really soft, 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 soft. I've had kids who have been run over by cars and nothing is broken. Kids have fallen out of windows and they bounce, depending on how they hit. So the smaller they are, the more pliable their bones are. So, it takes time for all these growth plates to become solid. So as birth, we talk about their muscles, tendons, and ligaments. So the muscles, tendons, and ligaments um, are a lot more sturdy. Okay. Anyhow, so the muscles and tendons are strong, and they actually protect the bones. So these muscles and tendons, if they're normal, will protect the bones because the bones aren't solid yet. So that's the big thing. That's why smaller children don't get a lot of fractures. All those toddlers and 4 and 5-year-olds that are falling all over the place and off the jungle gym, they tend not to get fractures because their bones are still pliable. So if a small child, so when a child gets a broken bone, you have to go with, does the story match the broken bone? Like, did they, a baby that falls off a couch is not going to have a broken bone. They'll roll off the couch onto the floor. I mean, unless that couch is 4 feet high, most babies are just going to bounce. They really don't get any broken bones. So if you have an infant that comes in with broken bones, you're really suspicious about how did that bone break. So that's a lot of child abuse, and we're not going to go into that, but just to know that those muscles hold those bones really, really tight.
I don't think you're actually recording. Usually we can see it and it
It
says
tells me
recording.
I'm recording. Last time I recorded to it says recording in progress. I think what happens is it records onto my computer and then it converts it and I'll download it to the Blackboard. Because up in my left-hand corner it says recording in progress.
Okay, thank you.
So that's what happened the last time I did. I don't know why. I'm not on the VM access for Blackboard because it gets so much interference in it. It's crazy. There we go. So the first thing we're going to talk about is clubfoot. So we're going to talk about a lot of the deformities from musculoskeletal. Um, the rest of the stuff that you get in adults, fractures and bones are all the same. So clubfoot is a common foot deformity. It's diagnosed in newborns. Um, it occurs usually in 1 out of 1,000 births. It happens to be on more males than females. It can be a congenital abnormality, so if a parent had it, it can be passed down. It can be bilateral, it can be one side. It's being recorded on my computer and then I'll download it. It's being recorded in my top left-hand corner. I don't know how else I can do recording if that's the only option that it gave me. Yeah, it's on the top. I'll make sure that it gets downloaded to the computer as soon as we get off. The signs and symptoms, the toes can be lower than the heel, they can be inverted. The point in the club foot is that their Achilles tendon is really tight. So because the tendon is tight, the foot can't move. It's rigid, it can't be manipulated, and involves a bone formation. I have some pictures along the way. They're classified in different ways. Postural often resolves with a short series of manipulation casting. Neurogenic, so some of these happen with neuro defects, so myelomeningocele, where we have that the spine coming out of the skin. They can be idiopathic, where it just happens without rhyme or reason. Its diagnosis is mostly visual during newborn assessment, and then they can do x-rays. Let's see how you can obviously see it. A normal foot is straight. A club foot, most of the times they come in, but they can go out. They can bend down. They can bend up. So a child, obviously, they try to fix this as soon as possible because trying to fix this as they grow older would be difficult. Their foots wouldn't form. So the nursing care is they're treated with serial casting. So they cast and then they wait a couple weeks and then they cast again. So it's over and over casting because you can't just bend that foot out. Imagine the pain that that would cause. And there's no real surgery. They can do the heel tenotomy, but if you do serial casting when they're newborns, you can slowly move those feet out without being invasive. Um, they're called a brown splint is one of them, and I'll show you what that looks like. And in severe cases, they'll do surgery if at 9 to 12 months the serial casting has not worked. Um, so the whole thing is to assess motor development. You want to make sure that as we're doing these changes, they still retain with their, they can still feel you tickle their feet. They still have all their neurological intact. So they're born with these deficits, but there's nothing else wrong with them. Like they can feel, they can pull it up to their mouth, they can move them all around. They're just different because that heel, that Achilles heel is so tight. So when you're assessing for motor development, so as they go through all these stages, as they're getting older and they're going through the repairs, are they still being able to move around? Now remember, this is a physical deformity. So the child's motor development should continue. The only thing that's going to hinge is perhaps they're walking, even they're crawling, but everything else about their development should be normal. After surgery, you're going to look for swelling in the ankle and foot. So when they literally just lengthen that Achilles tendon, they release it and then let it heal. So they can come out in a cast. Sometimes they'll come out like in a little manipulative device, but for the most part, they're out. You can provide pain management. The complications are that it doesn't fix. You know, they do the surgery and the deformity doesn't fix. Some kids don't develop a normal gait. They still have an awkward gait. A lot of physical therapy gets involved. But if you can fix it before they're walking and while they're still an infant, then it doesn't affect their development at all. Um, they can, you know, if one foot doesn't feel right, they can have a misgait. They can one favor one foot or the other. Some of them will walk on their toes. Some of them walk on their heels. So a lot of this is over time. Remember, children as they grow develop. And the biggest thing with children is if you miss a milestone, you need to be taught. So if you can do the surgery really young, when they're smaller, or do the casting, the earlier you do it, the less defects. But a child normally walks around 9 months, between 9 months and a year. So if you let this last, goes past, and a child doesn't get the opportunity to walk, they've missed the milestone. They now have to be taught that milestone. So if a child is in a hospital for any milestone, they then have to be retaught. It's not innate. They won't learn how to do it. If a child, for whatever reason, can't eat, they're stuck on an NG tube, they don't know how to eat. So when we're going to take that NG tube or that G tube away, you have to teach them to eat. The same thing is here is if they've not been taught to walk or they didn't get that skill to crawl or to walk, that you have to redo that. So they'll have to go through physical therapy. They use dogs now to help them push up and everything that they can because they'll miss that milestone and they won't know how to walk, which is kind of crazy. You would think they would figure it out, but it's not. If you miss a milestone, you then have to be retaught. So with clubfoot, it's serial casting, it's the brown splint, which I'll show you, and then surgery. Surgery and post-op surgical care is the same as it is for anybody else. You're going to watch the cast, you're going to watch the ankle, you can provide pain management and look for drainage and any kind of skin integrity issues. So on the top left that's the brown splint. So if a child's foot is normally already out, they'll put those little boots out in that direction. If their foot is already in, they'll put the little booties on in, and then they just change the bar in between. It's like, kind of like some people with braces, like they just change it and slowly move it. So as the child's growing, they're slowly doing it. So if it's those that aren't that hard, that's what the brown split looks like. The bottom is what the casting looks like. And they just keep changing the casting, moving that foot over little by little. The ankle surge that's there will show you how the surgical scar. They literally just the Achilles tendon in the back of their foot. They just lengthen it, and hopefully once they unattach it from the bone and they allow it to reheal through through casting, just like if you tore your meniscus or your ACL tears that literally come off the bone, they brace it and they put it together, and the muscle then reattaches to the bone and grows strong. So that's what this is. Um,
So I have a quick question. I might have missed it. Do they do the brown splint first or the casting or
they
does it?
it depends on the doctor. Most of the point, they try to do the brown splinting first. If you can do that at birth and it works. The other thing though is that some doctors prefer the serial casting, that they rather just cast. So, but if it's not corrected by the time they're getting into that 6 months or 9 months, they're going to go for the surgery because at that point your bones are starting to fix, your muscles are starting to fix, and they was just hoping that if they move your feet slowly over time, what you'll find is that a child that has idiopathic, a child that just has it, just born with some, if there's nobody in the family, nobody's ever had it before, those kids just have simple club feet. They tend to do fine with either brown casting or serial casting, the brown splint, because their foot will move in. But if you have a child that comes connected with like a cerebral palsy or another neurological disease, 9 out of 10 they end up having the surgery because there's just too much else going on, and they probably have that muscle is just too tight. So they try the non-invasive where nobody will do the surgery. You wouldn't do the surgery early, so they'll try the splint, they'll try the serial casting, and then if all comes fail, when you get past that crawling stage, they're going to do the heel tenotomy and try to. But the other thing too is that the surgery is not a definite cure. The problem is that there's nothing after it heals to prevent that Achilles tendon from getting tight again. So some of these kids, some kids, they go through all these things and they're done. That's it. They'll have the stiff sneakers. They don't use the orthopedic shoes anymore, but after they're done in the brown split, they'll get them the sniff sneakers, like running sneakers, so that your feet grow normally. But if your foot just goes back in again, they have to go through all this PT therapy over and over and over again to try to get that muscle to just relax and allow your foot to come out. Because there's no actual bone deformity. It's the muscle that's making your foot turn in the wrong direction. But as those bones get stronger and start healing, we can't leave them in that direction because they would end up being like that. So, no problem. So, education and discharge, you have to do the same thing. And remember that this child has clubfoot as an infant. These parents have never seen this before. Unless it's something that's happened in their family, they have no idea what you're talking about. They have to learn how to use the brace, or they have to learn how to use the casts. They have to understand that, that you're going to keep coming back for cast changes till we get that foot out. So it's a crisis moment for these families. When the whole thing with pediatrics is everybody expects to have a normal, healthy baby with all the fingers and toes and arms and legs. And when it's not, that parents is a crisis process. It's a grieving process for them. So it's the same as it is with adults. You have to tell them 3 times before they hear, because the first time they stopped at club foot. They heard nothing after that. So when you're educating them 2 days, 3 days later to go home, everything they were taught on the first day, they have forgotten because they had to adjust to my child's not perfect, and now what do I do? So you really have to talk to them about cast care. If they don't have an older child, they've never had a cast. No, you can't put your child in the bathtub. But some of them will think, oh, but I've seen teenagers in the pool. Yeah, they have a different kind of cast. The teenagers, they'll give them that cast that is quick drying, and they use the hair dryer, but you're not going to do that on infants. Um, you have to talk to them about a skin assessment. In the hospital, you're going to look at that CAT scan. You're going to make sure that their skin is not getting dried out or getting lesions on it, or a lot of rubbing. Sometimes you have to put like socks around the cast because this is newborn skin. Newborn skin is just a disaster. Anything you do to it is going to scar it. So, you have to teach the parents all of this. Teach them double diapering. So, the reason you do double diapers, you use a small diaper in the middle and then a bigger diaper on the outside, because the small diaper in the middle, so you take a size smaller and you put it on the inside, that'll catch the urine and the stool without going into the cast. But the big diaper is what they need to keep on them. So double diapering is a big thing. We do that, not only for kids who like flood a lot, like if you have a CP kid that only goes 3 times a day, but here for cast care, any child that's in a cast, you're going to try to protect because those casts can get nasty if all that stuff gets everywhere. So we double diaper a lot. You're giving sponge baths. You have to tell, it's a lot of emotional support that your child is, that don't let them label their child. Your child's not deformed. Your child's not, this is something we can fix. It takes time. It takes months. So they need all that emotional support. And remember that children are children and children want to play. We still have to get them through all those developmental milestones. So just because most of the time children are not like us adults. Children will do, you do what you have to do. I'm going to cry for a minute, and when we're done, I'm going back to playing. I'm going to go back to being who I am. They adjust to the cast really well. They adjust to the bars and the brown bar, but we still need to treat all the rest of it. We still have to help them develop. And if they can't roll over because they have that bar between their legs, you have to do it for them. You're going to roll them over. Remember that the development is very important. They still have to meet all those milestones. The parents still have to play with them. We still have to interact with them. So that's really important with clubfoot, is not just treating the clubfoot, but we have to treat all of the child. And you have to teach the family this, that you just don't stop treating your child until this is fixed. Just his feet, move along. You're still going to play and goo and all that other stuff. So that's important when you come to education. All right, any questions about clubfoot before we go forward? Speak up, join in. All right, so the next one is hip dysplasia, or it's called developmental hip dysplasia. So it's when the femoral head doesn't align in the hip. And a lot of it usually happens at birth. It happens to women more than men, females more than males. And a lot of times it can also come with the comorbidity of the neurological diseases. So a lot of the cerebral palsy kids might have it. It's
Um, is this what we check in the infant, in the newborn assessment? They're like gluteal folds. They're
Yep,
crosses.
yep.
Okay.
We'll get to them. You got it. So the one side their hip, so they can have both hips that don't work. They can have one that don't work. Normally it's just one side, but there have been kids with 2 sides. I put the x-ray up there so that you can see that the one, if you can see the femoral head is right into the hip, it's just fine. But on the other side, it's not in there. It's like not attached. So it's almost a dislocated hip at birth. I don't know why they call it dysplasia, but that's what they call it. But it really is like a dislocated. Um, A lot of the causes are unknown. It can be because of birth trauma. Okay. It could be genetics. There are some genetics, and usually that's when we get into the neuromuscular, or if somebody else in the family has had it, it will happen. Um, and then, so the development, so the assessment is asymmetry. As when we remember, the assessing children is no different than assessing adults. One side needs to equal the other side, right? Everything is symmetry. If I'm looking at your face, I want one side to look at the other. So now I'm looking at their hips. Their hips should look the same. But sometimes just looking at a baby, you may not see the difference. It may be a nice, pudgy, fat little baby. You don't see it. But asymmetry, the number of skin folds, babies have that baby fat. One side will have more, they'll be unequal. One side, the hip won't go out or won't come back in. The femur, one leg will be shorter. So we do this diagnostic test. So that's a Barlow test is adduction, which we're measuring the hip stability. The other one, I can't even say these names. Ortolani maneuver is where you physically, when you're moving it out, it dislocates the hip. X-rays, ultrasounds. The other sign that they use is Alley sign, where you literally just put the child on their back and pull their knees up. And you put their feet on the ground, and their knees will be uneven. They won't be, when you pull your legs up, your knees are at the same height. The child's will not have the hip that's dislocated will be lower, right? So that's a lot of it is just diagnosed by looking at the child and then these tests. So when we talk about treating it, as you can see, it becomes fun. So clinically, less than 6 months, they use this Plavix harness, the Bryant traction, or a hip spica cast. So the hip spica cast is exactly that. It goes around their hips and up their legs. And this is another one that's serial casting. They keep coming back and back and back because, again, this hip spica casts get dirty and the kids are growing. So they're the ones that are coming into that ortho clinic every 4 weeks, every 2 weeks to get the cast changed. The top left-hand corner, with that, it's called a Plavix harness. So it's booties that go on their legs, and then it's solid in the back, and then the straps come around. So it's literally holding their hips in place, so that hopefully those muscles then it holds that bone in, and the muscles in the bone then pull together. Over 6 months years old, they have to use closed reduction surgery, which is the one on the bottom where you're going to use the Bryant's traction. They can also go in and physically do just like, okay, on an older child, it's called a skiffy. It's a slipped where your femoral, kids playing soccer and your hip goes out. They can actually go in and they reattach the muscles and they put the bone in place. And so it's a closed reduction surgery. I have, honest to tell you, I have not seen a lot of kids go that far. Usually the Bryant traction, which is on the bottom there, or the hip spica cast, although three of those things are used, they tend to use the Plavix harness first. It's the least invasive. You can clean around it. The parents, you want to try to do a little motion, but you can clean under it. You can clean your shirts. Double diapering again. The kid on the top right, you can see is in the hip spica cast. It's the exact same things we talked about before. Those cascades, but look, he doesn't fit in that car seat, does he? So you really have to work on that. The parents have to figure out ways to make it work. Unfortunately, like you won't see that very much in this country where it's not treated. But if you go into third world countries or you go into really poor areas, where they don't have the money to go to a doctor and they don't go to a doctor and the prognosis is bad as they get older because there's a chance that if for whatever reason this child is untreated, they won't be able to walk because you can't walk with a dislocated hip. It's not going to happen. Um, so this is kind of something that happens at newborn. They try to fix it as soon as possible. Parent education. So the Plavix harness, the one where we have the straps around, it's on for 12 weeks. And we teach the parents to adjust the straps every 1 to 2 weeks. Why? What is a child doing every 1 to 2 weeks? Growing. They grow like weeds, right? So it's not like you and I can go in and put our seatbelt in the car and it's going to stay the same way. These kids are growing and they do a tremendous amount of growing in their first couple months. So you don't want those straps like, you know, going onto their shoulders and digging in, and then you would put pressure on the hips. So we teach the parents. A lot of them will come in to the hospital for the first couple week times and have it adjusted in the hospital so they learn how to adjust the straps. But for 12 weeks, you don't want to be there 6 times. We're going to teach them the same thing because when they're in the hospital, you're doing your checks, right? You're making sure that the skin is covered and the skin is good and that there's no decubiti or rubbing or remember again, this is newborn skin, this is baby skin. Baby skin tears really quick and scars quickly. So we want to make sure that it's not too tight. You need to make sure that they're still wiggling their toes, because if it's too tight, it's kind of like when your hand falls asleep, right? You can't move it. You're like, oh my God, my hand's dead. But if you look down, you could still move your fingers, but you don't feel it. But the child should still have the same neuro checks. They should still be able to wiggle their toes, and when you touch them, they should still be able to see they're touched. And when you're washing them, they should still know the difference between warm water and cold water. Because if for some reason those change, then we worry about, is the harness too tight? Is the hips, remember you have that femoral, the nerve that goes down your femorals, is that being pinched off? So we have to teach the parents all this before they leave, how to check this. You want to prevent complications from mobility. They make sure that they're changing those shirts, and it's hard to change those shirts under the straps, but you can do it. And learning to put, just say your child's 3 months, get me a 6 month shirt, put it over it. You have to get the parents past that, we're going to do this for 3 months. You'll be fine, but we need to figure out how we're going to do this. Again, for cast, it's the same cast care. Position on pillows, elevated till it's dry. You're always going to note the temperature and the color of the toes. What happens when your skin swells so much? Especially with broken arms. You break an arm, they swell, right? And then it can cut off the circulation to your hands. So you always want to make sure, that and that's what those neurochart checks are with casts. When you're walking into the room, you're going to test, going to feel their fingers and toes. You're going to make sure they're still warm and pink. Can I feel them? Are they warm and pink? Do they still have pulses? Teach them sponge baths again. Double diapering if they can do that. Skin care. This is where you actually do want parents to use lotion around those spots where the casts are. We're not big on lotion with babies, but if you have a cast on and something's rubbing, and you may have to be ingenious. You're going to have to, this is long 12 weeks. So you have to learn to use, baby bigger socks or daddy's t-shirts, whatever makes them happy. And the other part is what helps us heal when we eat. Nutrition and hydration are no different in children than they are in adults. So anytime, all of pediatrics, whenever they talk about the nutrition, hydration comes up, I promise you that's the answer. Because if you're not adequate, if you don't have nutrition to work off of and you're not hydrated, you're not healing. So a lot of this, remember, they're not small adults, but a lot of things don't change. A cast in an adult, the same cast care happens to the same child. So don't think like you have to relearn things. You don't. Just remember that it's smaller people and that you have to teach parents everything. So it will always be part of parent education, where I can pretty much assume that you as an adult know not to put, your cast on the stove or hang it up on somewhere else, but you have to teach parents everything. So parent education is going to be involved in all the care plans for all of these things, because you have to teach parents everything from scratch. All right, that's it for hip dysplasia. Questions? Guys aren't asking me any questions.
Are you recording this?
I am, but it's on my computer for some reason. It records on my computer, and then when I'm done, it converts it and I'll post it to the PowerPoint. I'll post it to Blackboard.
I was just wondering about the psychological, mechanical, genetic, and cultural factors. Are there any examples of those?
Which what are you talking about for the hip dysplasia?
Yeah.
Yeah. So the genetic factors is it can be if you like just like clubfoot hip dysplasia, if it's in your family, there's a positive trait that it will go down. It's one of those genetically linked things that will continue. So genetic wise, if it's in your family, it's the possibility that your child will have it. So usually it's genetic, it'll go on down. There is a chance that it will be idiopathic and just happens at random. Um, Physical factors, a lot of it happens, hip dysplasia can happen at birth. If his mom is a small person and you're pushing that baby through their very small pelvis, that can cause the hip dysplasia. That can dislocate that bone. Now remember, a lot of times that we don't catch it right at newborn, it's caught a couple weeks later. But that's what they mean by physical, is that it's caused by that trauma of being born. What else did I miss?
The cultural and
Part.
Cultural, it tends, there's some evidence to say that it happens um, more in some Latino families. And they put that there, but I can't say there's a lot to it. It has to do with diet of the mother when she's delivering. If the diet of the mother doesn't have a lot of calcium and iron and she's poor, then the bone development in the child the fetus is impacted. So then when she has the birth, there's more hip dysplasia because the bones aren't as strong.
thank you.
Okay. So this is the most difficult one to learn, is muscular dystrophy. Muscular dystrophy comes in many different formats. Um,
So basically, um, so the hip dysplasia is underneath the muscular dystrophy,
no,
right? All of these are part of muscular
nope,
dystrophy?
they're all very separate entities. Clubfoot is just born with clubfoot, so you can just have club feet, and that's usually the single. Um, most children will just have club feet. There is a pretension for children who have neurological disorders such as cerebral palsy to also have club feet, but club feet is on its own. The second one we talked about was hip dysplasia, and hip dysplasia happens on its own. It's rarely a comorbidity with anything else. So these are the different types of musculoskeletal disorders.
Okay.
So we're going to go through 5 of them.
All right.
No
Thank you.
problem. So muscular dystrophy is a group of muscles that are a gradual wasting of symmetrical groups. The problem is that muscular dystrophy is genetic. It's linked to the male. It's linked to the X chromosome. A lot of parents do not know that they have this until they have several children that then have muscular dystrophy. It's not. It happens very gradually, so that they don't their child will be maybe some hypotonia, but a lot of times some people will get tested right away, other people won't. So frequently in a family, you'll find one, maybe 2 children, and they're all in males. So that gets into genetic testing. So once you have your first child and they're diagnosed as muscular dystrophy, Duchenne's disease, the parents then are confronted with, if they want to have more children, do you do that genetic testing? Do you test for male or female? Because once you've had a male child that has muscular dystrophy, the chances of you have the rest of your male children having muscular dystrophy are very, very, very high. So you then have to decide if you want, they have to talk about when you get pregnant, do you want to find out the sex of the baby and decide if you want to abort it if it's a male? Very, very hard decisions. There's no right or wrong decision, but it's hard decisions. The muscular dystrophy does not have a good prognosis in life. Um, so a lot of families go through, it's a lot of genetic crises. to decide if you want to have more children and all the judgments that go with that? Did you continue to have children expecting to have a girl? Why didn't you abort? So there's a lot of peer pressure and social pressure that goes along with muscular dystrophy, and you need to know that. So it's a wasting of the skeletal muscles. There are many different kinds. Most of the muscular Duchenne's disease, which is a lot of. Did any of you ever see the Jerry Lewis marathons that he used to do?
Yep.
They were all for the Duchenne's muscular dystrophy. Yeah. So he had a child that had this disease. That child died early, and he decided to do, and he's collected a lot of money for this disease. So it's a dominant X-linked. If you have one boy with it, you will have all the boys with it. The etiology is unknown, but their best guess is that it's caused by a metabolic disturbance in the nervous system. So this is another also possible push for why we do prenatal vitamins to try to avoid, as women get pregnant, and most of it happens before they're pregnant, where they try to tell them now, do prenatal vitamins before you even think you're going to get pregnant. There's a chance, and the new research is saying that perhaps this is due to maybe a folic acid deficiency. But at this point, they'll tell you the etiology is unknown. A newborn may be severe muscle weakness. Remember, we talked about it. Babies expected to have normal tone. A baby that doesn't have normal tone, hypotonia, this is one of the things that we can look at. The muscles degenerate until they're unable. So remember that in neuro, for these type of diseases, it generally happens from the bottom up. So you don't all of a sudden not be able to breathe. Usually you would become unable to walk or paralyzed, and then slowly you can't breathe. So the neurodegeneration happens from the bottom up. Yes. Hypotonia, I mean, it can be a lot of different things, and that's why you have to check which it is. Hypertonia tends to happen a lot in like cerebral palsy, those type of spastic events. But a child that's floppy, it's then just a rule out. You literally have to go one step after the other to see what it is that could cause them to be floppy. Is it metabolic? Is it medical? Is it neurological? So once you have a child that has muscular dystrophy, the next one will automatically be tested for it. But if you don't know at birth, they start looking at this. So some children progress faster than others in muscular dystrophy. You can be a severe muscular dystrophy where a lot of them die before they're a year old because it goes very fast. And Duchenne's and Becker mutation, they take longer. So often these children can have some function and then slowly lose function over time. So there's muscular dystrophy. We all think of Duchenne's muscular dystrophy, but there are many different levels of it, but it all is the same thing. It's that gradual wasting of the skeletal muscle where it can't not only support your frame, but support the functions. Our muscles support the functions in our body, and if our abdomen doesn't work, you can't, the muscles in the abdomen don't work, you end up with bowel problems. If your diaphragm isn't being held up by muscles, you can't breathe. So this slow muscular wasting slowly makes them completely incapacitated. So what you've probably seen is the advanced stage where a child may have Duchenne's, which is milder, in wheelchairs that are trached with all the little fancy gadgets on their wheelchairs as teenagers until they die. What you don't generally see is a child that's born with severe muscular dystrophy that tends to die within the first 6 or 7 months because we don't have the ability to stop muscular dystrophy. We can treat muscular dystrophy, but we don't have the ability to stop it. So if you're born with it, the progression is going to continue. Some of the newer medicines are better at treating the muscular dystrophy and holding off the effects for a while. But if you're born with a very severe case of muscular dystrophy, there's just not much they can do. I mean, we can trach children, we can put them in ICUs, but that doesn't change the progression of their disease process.
I have a question.
Yes.
So which one again is the most severe Duchenne?
It's not. Duchenne and Becker's are the milder forms, but Becker is the mildest form there is.
Thank you.
So usually what you see out in the world are people who have Duchenne's and Becker's. What you don't see is the severe muscular dystrophy because they never really leave the hospital. They never really get well enough. A lot of them die early.
Thank you.
No problem. So found this. This is kind of helps things. So when you look at this, the clinical manifestation, so this is of the older child with a milder form. The shoulders and arms are held backwards. See how they have that kind of like that S curve going on? Their belly sticks out because they don't have any muscles to hold it in. Their legs are thin, all that. The muscles that are in your arms and legs never really develop strength because of the wasting that it has. They can get some contractures in their hands and feet. They initially start out being floppy. As they get older, they get contracted, and that's mostly just the atrophy because it actually takes muscle strength to hold your hand out like that. It actually takes muscle strength to have your foot sit flat. So if you don't have that, so they're tall, they're skinny, they really can't hold themselves together. Like I said, they may be just a floppy child or weak child, but it progresses to where they can't do anything. So this would be the child that actually went up to being a teenager and developed some of these. So Duchenne's muscular dystrophy, the signs, symptoms appear after the child is able to walk. So this is what happens is that around the age of 3 to 7, they might have been weak, but they were still moving around. They might have been weak and they were still moving around. By the time they get to 3, now I'm going backwards. So I was walking across the floor. Now I'm barely able to get the crawl going. And this is when, in Duchenne's, they're finding out that they have this muscular dystrophy. So how many people when their first child is 3 or 7 already have another child? So imagine you have a normal 3 or 4-year-old boy and you have a normal 2-year-old boy to find out that that 3 or 4-year-old has muscular dystrophy, and 9 out of 10 when they test that 2-year-old, they will also have muscular dystrophy. It's male linked, so if they're both males. So in Duchenne's muscular dystrophy, that's how come you'll see families with 1 or 2 children before they realize what's going on. It's a general muscularized weakness. They use upper extremities to compensate. So I remember as that it gets weaker from the bottom up. So their legs get weak first, before their chest, before their abdomen, before their arms. So they go from, so that's what's called the grower sign, where my legs are really weak, but my arms are being used to pull up. So you will see that in muscular dystrophy. You will see that in questions. That's why I have it in big bold letters so you see it now. That is a huge sign of muscular dystrophy. It's called the grower sign. Using your upper extremity to make up for what your lower legs can't do anymore. They first they're walking, they're talking, they're running. Now all of a sudden I can't. A lot of them come in. The first sign is they can't ride their bike anymore. They're on those trike bikes, and all of a sudden they can't get it together and they can't get it moving. And the parents are like, "What's wrong with my child? Why all of a sudden can't they pedal the bikes anymore?" Their calf muscles will become weak and atrophied, and then most often they're unable to be ambulate by the age of 12. Now, like I say, it can go sooner, it can come later. You might have children that are fine until they're 8 or 9 and they last till they're 14, or other kids, but usually between that puberty age is where they become wheelchair bound. The atrophy is so that they cannot function. And then as it moves forward, they're no longer able to, the respiratory the chest muscles don't work anymore, so they'll end up on a ventilator or trached. For a lot of times, the parents have really no choice because remember, there's nothing wrong with their brain. These kids have normal brains. They are not mentally retarded. There is nothing wrong with their brains. So you have a normal child that their body is failing. So it's kind of like having an adult that was fine all their life and all of a sudden had this stroke and nothing works. So that's what's happening to these kids. So you have a 12-year-old that can still, their brain is still working. They can still go to school. These kids are still taking calculus and AP stuff as much as they can until they're no longer able to. And just like for an adult, anybody who is trached, and remember, their muscles can no longer move in and out. They will die from respiratory failure or cardiac failure, usually in their early teens. So it's a gradual neurological wasting that goes from the bottom up. And Duchenne's, they'll be fine until they hit that growth spurt between 3 and 7, and then they're no longer fine. And the biggest thing is that riding that bike, that's one of the first signs is I can't ride my bike anymore. And like anybody else who's immobilized, trying to get it so you don't have to remember one thing for one topic. Anybody else who's immobilized, you get into respiratory failure and cardiac failure. Because I can't, now they have muscles that just can't move those lungs in and out anymore. So remember I said muscular dystrophy, the muscular dystrophies come in many sizes and shapes. Some kids can do more than others. They will have contractures because we no longer have those muscles that can keep my body straight. So their hands just kind of flap and then eventually become contracted. They have atrophy, infections. Obesity is listed as a complication. It's not so much now, mostly because I think we've identified this as an issue and they really try to be nutritionally sound with these children as they're growing because our larger child in a wheelchair is going to have more complications with their skin integrity and their body. So we try to keep them slim. Diagnosis is family history. If you have one child, you'll have another child. If there's muscular dystrophy within the family, even if it's like my second cousin remote had this, they'll test to find out if you're a carrier. There's no way to know if you've never been tested to know if you're a carrier or not if nobody in your family's ever had it. Serum creatinine kinase levels are monitored because they go up. They elevate because of the muscle wasting. A muscle biopsy can be done to confirm the diagnosis, though I can't tell you that they really do this much anymore. And an EMG, what is it? Anybody know what an EMG does?
Test your nerve.
Yeah, it tests your nerves inside your muscles. So it looks to see if I pinch here, am I going to react? So that's the first sign. That's an early test they can do to find out if the muscle wasting is going from, is it muscular dystrophy or is it something else? Do I have a connection problem? So treatment for muscular dystrophy, there's no effective treatment. There's no cure. They use some of these medications. Exonagist 51 helps lessens the symptoms of muscle weakness and atrophy. So it slows it down, but it doesn't, like I say, nothing will abort it. Corticosteroids, because remember that your body's reaction to anything that goes wrong is an inflammation reaction. So just like when you have spinal trauma, they will give you steroids to try to keep the muscle from swelling so much that it's impinging on the nerves. They give you corticosteroids so that you don't swell enough to impinge on what nerves you might actually have left. The goal is to keep the child as active as long as possible, so we do a lot of physical therapy as far as they can, as much as they can. Gene therapy is the new thing. It's out there. There's a lot of geneticists that are giving different types of drugs to try to alter, to try to stop the effect. So the point in gene therapy is if I can stop the X chromosome from doing what it's doing, perhaps I can stop the disease. It's very questionable. It's very researched. There's nothing out there. Genetic counseling for parents and siblings. If you have a sister, she probably is a carrier, so now she has to deal with that as she gets older. So the management for these kids are to promote independence, mobility, and psychosocial support for their family. When these parents first find out when their child, it's bad enough to find out when your child is maybe a month old that they're not going to live, but then to find out I have a normal child and then all of a sudden at 4 years old I no longer have a normal child and the outcome for my child is devastating, right? They just don't have a positive outlook at all. So it's crisis for the family. They need a lot of support. Thankful to the Jerry Lewis Foundation, there's a lot of help for these families. They get converted vans so that they can travel with these children. They get wheelchairs. They get everything they can possibly do. And the whole thing is that remember that their brains are mostly normal. So they can still interact and they can still be part of your life. So it's a lot of counseling for the family. They have to go through a lot. They have to go through the grief process before they even get to, and they will grasp at all of these stores. They want all of these drugs in the event that something's going to work. Can't blame them. But it does take a lot. And the fact that they're going to need counseling because then they have to tell other daughters when they grow up about this genetic counseling that UNG may have to carry this. So get into nursing care, maintain independent living for as long as possible, prevent respiratory infections. If you know, as the child becomes more atrophied, they're on the same. We're talking again about the skin integrity. We can use special beds, transferring, nutrition, and I told you nutrition will come back again. Anytime we talk about a child and their skin care and their nutrition, nutrition helps healing. The more nutritious they are and the more we maintain their weight, the longer they have a chance of living without that respiratory infection. They treat things right away. If a child gets sick, they treat it right away. They don't want this to become a respiratory infection. They do every therapy known to man: physical therapy, occupational therapy, respiratory therapy. They'll have them on horses. They'll have them with dogs. Anything they do to keep the mobility, because as long as we keep the mobility, we can keep that atrophy in check. You want to maximize their quality of life. Education and discharge instructions to the family. A lot of this is teaching the families to provide meticulous skin care. You have to teach the family about nutrition. You also have to teach the family about mobility. How do I move my child? They will come in and out a lot as the child grows. How am I able to move them? There's a lot of support groups, and the Muscular Dystrophy Association will provide them with tons and tons of stuff. Everything they could possibly need. A lot of people don't want to reach out, but they do really assist these families.